Eric Michelson returns with Dr. Robert Jones, a distinguished professor of surgery at Duke University in North Carolina, to discuss revascularization in diabetics. Back to the drawing board.
Bob, welcome.
Thank you, Eric. It's great to be here.
You're a champion and have been a champion of randomized clinical trials in cardiovascular medicine and surgery. I'd like you to at least give us a perspective to begin with from 50,000 feet of why this is important.
Well, thank you, Eric. It is very important that we understand the sources of our information, that we make these critical decisions for our patients, and the validity. And the two are kind of separate. Everything that we try to learn, we want to be valid, and we put it in our database of generalizability when we see the next patient, the next patient, the next patient. It becomes especially critical if that patient has upfront risk that is counterbalanced by the promise of some good. And that's the description of what surgery is all about. So particularly randomized trials are very tricky and hard to do in surgical patients and hard to interpret and to generalize.
So give us some examples of some of these major trials and what advances have occurred.
Well, the three big trials that people I think would all be familiar with are the early trials of whether coronary surgery was at all valuable. And those were a medicine versus surgery approach. And the VA trial, the European trial, and finally the CAS trial. And those trials basically, interestingly, in retrospect, only showed things that remain that we use for decisions if they were validated by some secondary analyses.
These were initially, though, very important in guiding which patients might be candidates to get any benefit from various procedures that were now considered to be routine, like bypass surgery.
Exactly. And I was with Dr. Tim Tuccaro and the others that looked at the VA data. And they had something around 50 patients that they found that had left main disease. And when they looked at that subset of patients, they found that the patients with severe left main disease were the only patients they could show a benefit for surgery.
So it is interesting because you set up the trial, you have some inclusion, exclusion criteria, you do certain things prospectively, but sometimes the most interesting information comes out of some of the retrospective looks that then require additional new trials.
Yes, of course, because then they didn't really know what now every medical student knows after they finish surgery, that it's the severity of coronary disease that kind of indexes how much potential benefit there is. And they were operating on patients that surgeons were used to operating on, try to get the lowest risk patients you can to operate on, and there wasn't much benefit in that subset. But when you found the third that was the highest risk, and especially the left main patients, those did benefit. Now, the European trial was ongoing, so the European trial just stopped enrolling the left main patients. They'd enrolled some by that period of time because of the safety. Those considerations are doubly important in the surgical patients. It's one thing to take a placebo and a medication that's been tested in animals, but when you're talking about broadly applied surgical procedures, that's a different issue.
And you've advanced the field, other trials, Barry, Stitch.
Right, and of course one of the big questions about Barry now had to go to a second trial. That was the finding when the DSMBA got about 6 months away from where we'd planned to stop and looked, and there was a very significant difference in the diabetic patients.
Now remind the Barry trial was?
Bypass angioplasty, revascularization, investigation, 17 good centers, 1,800 plus patients.
Yes.
There was really not much difference in the total population. It really was the diabetic subset that did better if they had cardiac surgery. Now as we look back using registries, it really was more the diffuseness of the coronary disease that really made the difference. And the point that I think we've learned as we go forward is that we can't use randomized trials only. They need to be put in context with registry information that has the broad population so that you can relate this subset that you can randomize ethically. Now, that subset should be at the interface of your question. And so it really is the pivotal group of patients, but you put it in a broader context by having some large registries. And fortunately, we in the ACC do have, in collaboration with the STS,
the STS?
Society of Thoracic Surgeons.
Thank you.
The opportunity to use our information as we have used information now for many years at Duke. If we will simply capture various key points of entry of patients, like an imaging study time and the results in a very consistent description, particularly the imaging study of coronary anatomy, which we've done at Duke, becomes extremely, extremely powerful then to be able to take these described populations and apply the criteria of randomized trials. And for every one of these randomized trials, including the surgical therapy of ischemic heart failure trial, which we've just concluded, of low ejection ischemic heart failure patients who are eligible for randomization to medicine or CABG. And we have found in that population what our database showed that is exactly what we predicted when we started that trial.
Which is?
Which is that CABG is actually better, but not as much better as you might think. And we have another 5 years of follow-up, and our database tells us when we get to 10 years of follow-up on these patients in the coronary disease, that is, of course, a 40-year disease in most patients, that we will definitely have a very positive answer with Stitch. Right now, we have the trend. The medical patients had, of course, a little bit lower early risk, and the curves crossed at about 1 year. And now the population is being followed, and the survival is better in the CABG cohort.
And Stitch was a trial of?
Patients with ejection fraction 35 or less who are amenable to coronary bypass grafting and eligible to not have coronary bypass. So they can be randomized to everybody getting intensive medication, half being randomized then to coronary bypass.
Yes, so ischemic heart failure in that population.
Yes.
You're pointing out the importance of having high-quality data, characterizing your patients the best we can, using the findings from the randomized trials, but then having the balance of saying, how does my patient fit into the picture that was studied in that trial?
I often describe it as a kind of a building. If you sit in a building, the things you don't notice are almost more important than the things you do. We're in a room now talking to each other, but what's holding us up is a bunch of steel we don't see. The randomized trials are the steel of the information data that we have. But if we were sitting here and had to have just a board across two planks of steel, we wouldn't probably function very well in this discussion. So you do need other information to fill in. The registries can fill in information. The randomized trials really point to one decision point where you go to a patient and say, I'd like to randomize you. Everybody needs medicine. We'll give you medicine, but we don't know for sure that you need bypass surgery. And oh, by the way, you have a pretty high mortality with operation because your left ventricular function is so low. Can we randomize you? But fortunately for us, 1,212 patients said, yes, you can. That's the group that went into this limb of the trial.
So again, I really want to emphasize the value of having randomized clinical trials in cardiothoracic surgery and cardiovascular medicine so we can make these decisions. But you're talking really about almost a three-legged stool where you have randomized clinical trials, you have registries, and now you have the patient in the office that the clinician still has to figure out, where does my patient fit in?
That's exactly right. And it cannot be a simplistic decision. You need to understand the pros and cons, the strengths and weaknesses of all our information sources. And there's nothing magic about a randomized trial. It does one good thing.
So as the distinguished professor and elder statesman in this area, what's next?
Well, the next thing for us in the college is to be sure that we blend with common definitions all the cardiovascular patients. We don't call them surgical patients. We don't call them imaging patients. We don't call them exercise stress patients. We call them cardiovascular patients. And there are a certain number of very few variables that really matter. And those variables we need to capture with standard definitions in all cardiovascular patients, whether we're talking area of imaging, of medical treatment, surgical treatment, catheter-based treatment, any kind of treatment. That's our future.
And how does this apply to my cardiology practice colleagues who want to know what should they be doing in the office?
Well, they need to start themselves. You know, the reason I can say this so firmly is because at Duke we started back in 1968, and every patient at the time of cath has a certain amount of very core, small, good information that is well defined. And then that has happened, so now we have literally hundreds of thousands of patients that we can now put criteria on that match the randomized trials. Every time we do that, we can predict the outcome. We can predict the outcome in other registries that are well defined in Poland, the New York registry. And so this information, when you do it in a careful way, is basically the gold that we have to spend when we talk to our patients.
Well, perhaps the electronic health records can help in this regard in terms of standardizing and assessing as we go as quickly as possible the outcomes and benefits of these integrated approaches.
Not only we will help our patients, we'll help society when we do that, because we'll get to the core of the value we add every time we see a patient.
Well, Robert Jones, thank you very much.
Thanks.